Hey everybody, welcome back to the You're Not Broken podcast. We are going to talk about all things organizationally sexual today because we're going to talk about Ishwish, which is the International Society for the Study of Women's Sexual Health, ishwish.org. Go check it out. They're probably the thing I shout out the most on the podcast. And today I have the current treasurer, Dr. Heather Quaile, with us today. Welcome to the podcast.
Thank you so much for having me. Yes, you do say ISSWSH quite a bit.
She can back me up.
I will. Not only am I the treasurer, but I listen to your podcast on regular and I hear it all the time. We talk about it all the time. Our membership has grown.
Tell me how much the Ishwish membership has grown because we want people to be members of Ishwish. Who can be members of Ishwish?
So when we did our board meeting this past year, and I actually presented it at the scientific meeting, and now you're going to make me go pull my PowerPoint for it.
I don't need exact numbers.
We've actually grown to almost like 97% in the last year.
You've grown 97%?
Significantly. I may be a little bit off on those numbers, but yeah, like huge. And honestly,
why?
It's probably because it's the most collaborative organization. And I can say this.
I agree.
And I can say this being a nurse practitioner because sometimes we feel like the redheaded stepchildren and that you go to these societies and it's very MD driven and they don't love us in the same way that ISSWSH does and whatever, for better or for worse. ISSWSH is so collaborative. You can be an MD, you can be an NP, a PA, a sex therapist, a sex counselor, a pelvic floor physical therapist, and we want you and you're welcomed and everyone has a space at the table at ISSWSH. And I think
that's all true.
I think it's just why it's my favorite society ever.
Dude, and also founded by a urologist.
Yes.
Which I made it through an entire American urology residency, not knowing this thing even existed, let alone was founded by a urologist.
Exactly. And when I say MD or NP or PA, we want all different, who can do sex med? Everyone can do sex med that are specialized, whether you're urology or gynecology or urogyne or even primary care.
Psychiatry is there.
Psychiatry, all of it. We all should be talking about sexual health, in particular for women, because that's what we specialize at ISSWSH. But every person should be asked about their sexual health when they are interacting with their healthcare provider.
We all got here because of sex.
Yeah.
Like it's so incredibly universal. It's embarrassing. It's so universal. It's embarrassing. So I agree. I found Ishwish because of my story was I didn't know how to deal with female sexual health. I'm a urologist, so I was pretty fine with the penises. And I went to their fall course. Check out their fall. Now I am going to put you on the spot. Damn it. Is the fall course open for registration?
The fall course is not open just yet. It should be open soon because we're changing venues. So
Where? Are you still going to do in Phoenix?
Still going to be in Arizona, and I believe still in Phoenix. It's not as far, I mean, like it's equidistant, but it can actually take more people in the room so that we can have more registration for it. So we're actually excited about it. And our education chair is kind of changing we've changed the format over the years to be more inclusive. It has like gender affirming care and some other really cool nuances. And we're still evolving.
The vulvar derm. When I went for the first time, Dr. Andrew Goldstein did it. The vulvar derm was excellent. I did the vulvoscopy course. It was one of my first dips into hormones. I went to that fall course before I was doing female menopause hormone therapy. That fall course was where I learned that women aren't born without a labia minora and they just happen to be 70 years old.
Yes. It was so eye-opening, like learning about lichen sclerosis. I mean, it's one of the things I see it a lot. I'm on a lot of different Facebook forums, particularly one like Women's Health Nurse Practitioner and other things. And it's interesting what people put out. I've treated yeast. I keep treating it. It's not getting better. It's not getting better. And in my brain, because we're Ishwish folks, I'm always like, well, has anyone biopsied her and looked at lichen? And it's like, that's just where our brain goes. But I cannot believe how many people have no clue what lichen is as healthcare providers.
100%. And how many women have pelvic issues and who've never had an exam.
Or that we're not trained to assess the muscles properly on a proper pelvic exam. But you come to ISSWSH and we will darn well teach you how to do a good pelvic exam.
It's so great, and you keep going back. I went to the fall course multiple times. The last one I went to was the online one because it was COVID.
Mhm.
I haven't been back since it was in person again. But every time you go, you will learn more. It's so incredibly high yield. And I want to contrast the fall course with the spring conference because I think they're very different.
They're very different. Very much so. So the fall course is going to be like very high level, tons of everything all meshed in. So you're learning about pain and orgasm and desire arousal. And we split it up into categories where when you think about our annual meeting, it's a lot of the newest, the latest, the greatest, and very research driven, where you kind of get the best minds all coming together to bring what is the newest nuances in sexual medicine for females and tons of research. We do lots of podium presentations. I learned so much from the posters. The posters is one of my favorite things we do at that conference.
Yeah, the conference, so the spring conference tends to be more like cutting edge. This is new. Where are we going to go with this? But very open to like, I want to say thought leadership, but people are open to new ideas. That's what's also very cool about Ishwish. In contrast to, I'm going to call it out, in contrast to the Menopause Society,
Yeah.
where I feel like I went to the Menopause Society conference for the first time last year. The lack of encouragement for curiosity was profound. And I think, one of my themes that keeps coming back this year with the podcast is curiosity is everything. And if you don't have curiosity in the annual meeting, your group's dead. Like
Yes.
what are people going to keep coming back for? Right. And
Agreed.
Ishwish is very good with curiosity. And, the founder, Dr. Erwin Goldstein, he's always raising his hand and being like, what about this? What about that? Why aren't we doing it this way? Right. Like curiosity is a cornerstone of Ishwish.
100%. And one of the things, and if you want to be a researcher or you're a new student, like this is one of the things Rachel Rubin always says is that sexual medicine is your place where you get to kind of do newest, latest, greatest, because we don't have tons of funding and tons of research in sex med. And if you want to be known for something, sex med's where you should get known for it because we're open to it. The other thing I want to say, and you can cut this out of the podcast if you go in to edit it, but we don't charge our members to put in an abstract. As you know, on my text chain, I was pretty angry the other day where I was like, what? We have to pay to submit an abstract? And we kind of bantered about that a little bit.
Yeah. Well, I think, supporting researchers of like, yes, it's a job, but it costs money, and to have to pay to play. The problem, I actually asked ChatGTP about this because I was like, I want to know the pros and cons of making people pay to play to submit abstracts. And one of the problems is, well, if you're being supported by big pharma, it sure is easier to pay to play.
Correct.
And a lot of things, especially in sex med, and I would say women in general, is like, there's a lot of clinicians doing research on the bootstraps. They're on a shoestring budget. They're doing it out of the goodness of their heart.
So
why do they have to pay to get this out there?
So I have a twofold answer for you on this. One, in the state of the economy, I mean, the world that we're in right now, we're cutting funding left and right. I have someone in particular who sits in my mind right now that is someone in the past on our ISSWSH board that had a bunch of her money cut this year because of just funding. But she's a sex medicine person. So how does she get her research out there? Her funding's been cut, but yet there are organizations that want to charge for abstracts. I can wear two hats on this. I've been on the other end of the abstracts where I have to decide what abstracts go to Ishwish. That's the job of our scientific chair. So it is an unsurmountable amount of work. But also, I think that there should be pride in your organization to pick these great things to bring them. And when you, like you say, when they're basically bootstrapping themselves to get the research out there to charge for it, I really struggle with this big time.
It's like not very welcoming
at all. And it's why to the society I will not name, I won't submit an abstract this year. I've thought about it and I'm like, no, it's out of principle now. I've been on the other end of having to accept abstracts and know it's a lot of work, but yeah, it's really made me question and paused on that one.
Yeah. The other go-to, and I think the reason why I shout out Ishwish so much on the podcast is because women, people tend to ask me, where do I go to find somebody to help me with testosterone? My answer is Ishwish. And the reason for that is people who understand sex med understand the role of hormones in sexual function. And if you understand the role of hormones in sexual function, you also understand the role of testosterone in all bodies in sexual function. So although Ishwish is kind of the umbrella for sexual health, I think they're probably the best trained group. If I was like, go to a place and type in your zip code, Ishwish is, I think, the best place to, I mean, even some of the big online hormone places, they can't all do testosterone, right? Because of DEA and state restrictions and stuff like that. So it's like consistently, Ishwish is pretty good universally. Because even if I was to recommend one of the online companies, I can't guarantee Michigan's going to work. I just got a post today from a woman in Pennsylvania, and she said it's illegal to give women testosterone in Pennsylvania. And I'm like, first of all, I don't think that's true.
No, it's got to be because of telehealth laws.
Yeah, to me, I'm like, maybe a provider told you that, but I'm basically like, my answer for everything is like, show me the data, show me the paper, show me where this is, because I'm like, if it is illegal, I got some content. But I just think Ishwish is
I know a bunch of PA providers. It probably is that they don't have a DEA, and it was probably a telehealth visit, if I was to guess, or they just don't understand it and they don't want to prescribe it.
Yeah, don't tell women it's illegal though.
Yeah.
It's not illegal.
Again, another thing that we have to navigate through all the noise.
Yeah, totally. So yeah, I think Ishwish is best for female testosterone. I can't say everybody does it, but I think it's an open place to find a provider who can do it.
Well, because we also wrote the consensus statement and then had everyone back us. So that's helpful. The other really cool thing we're doing this year, and it actually launches at the end of this month, is we have an advanced hormone course. So I'm super excited that ISSWSH is actually going to be a holder now of a tried and true hormone course, so that maybe we're not so scared and can train the masses.
That's great. One of the other, I think, brave things that I got from Ishwish in the beginning, and they still do this, but it stuck out, is like, culturally in medicine, it's not supported to question side effects of birth control pills. And Ishwish, again, it's a curiosity of like, these medications have sexual side effects. Nobody talks about them. That doesn't mean they're not there. And so really, like, saying, let's understand these medications more fully so we can better help people. I thought that was just a very, maybe brave is the wrong word, but it's like, that's where I got like, oh, these medications don't just make you not get pregnant. They have other body effects.
Exactly. And no one really talks about it, either A, because they never learned it and didn't know. Like, it wasn't until I started being a regular at ISSWSH many, many years ago that I'm like, oh, yeah, birth control is great for preventing pregnancy, but let's talk about the libido and the sexual side effects and the vestibulodynia and the hormonal effects and all the things that it can cause.
Totally. So how did you get involved in Ishwish?
So I got involved in ISSWSH because I was kind of in that typical OBGYN practice, been there for many, many years. Everyone kind of knew me. They'd come to me for their annual exam. And as you're closing the door, right about when you're about to walk out in an insurance-based model, and you're like, do you have any questions you want me to answer? And it's like, actually, and they get to know you after all these years, I have no interest in sex. Oh, okay. Well, we were done with our annual exam and I don't really know how to help them. And I would hate to tell them like, hey, we have to start another visit because, they already were there. So it was trying to come up with how you bring it up in the annual and make them feel like they're being validated and seen and heard, or do you bring them back for another visit? But then if I bring them back for another visit, I'm not knowledgeable enough to know what to tell them to do. And so I did a lot of digging over my several years, and I found ISSWSH. And the interesting thing is I actually went to an ISSWSH back in, I want to say it was like around 2008, 2009, and went to a conference and kind of went once or twice. And I brought it back to the practice. And I remember telling the guy that I worked with, and I'd worked with him, I was there for like 10 years. He's like, no one wants to pay for libido. You'll never get it covered with insurance, and it's just a waste. And I was like, okay. And I had written up a soap note, a template, all the things. And he's just like, yeah, no. And so no interest. So I kind of like left this idea and didn't go back to an Ishwish again until right around 2016, when I left, moved out of the state and joined another practice. And forever then it has kind of been my home. And I'm like, I will build something around this. And that's kind of how it worked. And then I met the Goldsteins and got the opportunity to go spend some time and precept under him. And they've kind of forever been my sex med parents.
Oh, I love it. I think they single-handedly have shaped sex med in this country by
And
their
they're so open to training and teaching everyone. Like they're just the nicest people in the entire world.
yeah. Yeah, they're super just their attitude and their openness and their curiosity is like, Dr. Goldstein embodies the true expert who knows everything, understands they don't know much at all.
Yes.
Right? And he's very, very he embodies that of like, what about this? What about that? What about this? And you're like, dude, if he doesn't know, like we got some work to do still.
Yes. Yeah.
Incredibly exciting. So I did not make it to Atlanta to the ISSWSH 2025 conference because I was in Sydney, Australia.
Getting a standing ovation in the Sydney Opera House.
Getting a standing ovation from Australians who don't stand.
Don't stand. Love
Petting
it.
koalas' asses.
Love it.
I know. So I would have been there, but I was not. But I was not there. So you were kind enough to send me the agenda from it. Can we talk about like what you thought were some highlights, and then I'll pull out some that kind of were curious to me.
Yep. So of course, like I said, I'm pretty impartial to whenever I can hear Dr. G, the OG, to go, Irwin and Barry Komisarek get in a room. It's like in the room where it's happening kind of thing. So really kind of hearing a lot about the orgasm process of care and kind of some of the things that that are coming down the path with it.
Yes.
I think in Irwin's speak, it was so above my head in some of the things. And so I have a colleague that actually put it into concise little mapping of this is this and that is that. But I think there are some really cool novel approaches that I'm super excited to kind of see come down the line. I think some of us are doing some of the things, but like I'm kind of more intrigued on like, where do ADHD meds, where are they going to fall with this? Another super interesting thing that he talked about is he showed a bunch of pictures that were in his PowerPoint. And he said, I want you to tell me, is the patient experiencing an orgasm or pain in these pictures? And I think that was just kind of this mind blown moment that they kind of exist on that same neural pathway. And you're just like, oh my gosh. And so my running joke, because I'm really close with the Goldsteins, is he's just like, do you realize like when you're having sex, your eyes dilate and this is what's going on and you make the face? And I'm like, Irwin, I'm going to ask Steve to snap a picture right when I'm having an orgasm and I'm going to send it to you because it'll probably make you so happy for your day. And we kind of joked about it at dinner one night.
It's true. Yeah, they're like I think it was last year's ISSWSH 2024 where they talked about they had the water faucets, right? So like what your body, to explain this for people, is like your body has to have excitement but also inhibit pain at the same time, because like that amount of friction in a non-sexual event is uncomfortable.
Mm-hmm.
And when it is a sexual arousing event, you actually have to kind of inhibit the fact that you could be experiencing pain if this wasn't sex.
Right.
And so kind of their process and model of looking at orgasmic dysfunction is breaking it down, is to like, is it too much pain? Is it not enough excitement, or is it not enough inhibition? Can you get close but you can't go over the waterfall? Do you go over the waterfall too quickly? Like they kind of are really kind of creating a structure in how to think about orgasm, which it's fun to kind of like, I just wish like the paper was published already. I'm kind of in a hurry.
Yeah.
But it's also exciting to actually like kind of watch the cake be made.
Exactly. So, and I don't know that the paper is going to, I'm kind of thinking by the end of this year. I was hopeful it would have been more like beginning of the year, but
end of 2025 is worth waiting for.
Yeah. Which means it's almost December. That's how I look at the trajectory. I'm like, crap, we're back at the holidays again.
I'm like, I thought we were gonna wait a couple more years for an orgasm pathway.
No, it should be the hope is that it'll be out this year, which is
No
exciting.
way.
Yeah.
Are there any are there any meds in the pipeline FDA approval wise for orgasm, or are we looking at if we're going to use pharmacologics, everything's being used off label?
I wanna say from what I remember, because I need to go back and look at all of his things. Because in my mind right now, I'm like, what were all the things? I think a lot of it is I think most of it is gonna be off label, and that's the sad reality is most of what we do in sexual medicine for females is off label. That could be a whole other day's podcast that you post about a lot. We have nothing really for females. We don't even have freaking testosterone for us. We have 2 drugs that are available that work about 40 to 50% of the time for females.
And are off label for postmenopause
Correct.
until that gets changed.
And
On
are
label in Canada.
and are off label for arousal, and they're off label for all the things.
Orgasm.
So a lot of it is off label. Like I said, the ADHD drugs, there's Busbar, which falls into, is Busbar an SNRI, SSRI? No, it's neither. Hold on. But there's some other ones, again, all of it off label.
Do you have any success? Do you have anybody on Wellbutrin for sexual dysfunction?
So here's my take with Wellbutrin. I do have some patients that take it for sexual side effects, and I think it works well when you have a true SSRI that is kind of causing a lot of things. So like your tried and true Prozacs and your Lexapros that work so great for depression and they need it. But then if you kind of use a taper up of the Wellbutrin, I've had a couple of patients actually do okay. I have them actually do better on sometimes the Wellbutrin than they have on flibanserin, for example. I do use flibanserin though quite a bit with SSRIs, and I've had good results for some and some other results that don't necessarily work for others.
Yeah, I mean, I think, sex med is not unique in the fact that like not everything works for everybody. And at the end of the day, sex is it's kind of like, blood pressure of like there's like 20 different reasons that your blood pressure could be off. It's not one reason that everybody has a blood pressure issue. And the same thing with sex is like it's not always the testosterone super interesting on Instagram, right? Because I have like this massively stoked camp about testosterone for libido. And then but there's a fair amount of women who are like it didn't help my libido.
Yeah.
And it's like there's no paper
I have
that
other women, like I have women with actually lower testosterone numbers than I would like. But then they're like, yeah, I'm having effects and we're great. And then I'm just like, okay, then maybe I shouldn't even be following labs, even though the consensus guideline says to get a total T, but then they don't direct us where our parameters should fall. And you go to these courses and they're like, they should fall between X and X maybe, but we don't know.
no, we don't know.
And so, but then I have other people telling me, like, for me personally, like when I don't use my testosterone, my bone and joints hurt. Do I think it always helps my libido? No, but it sure as hell helps my carpal tunnel and my hip pain and all the other stuff. You and I have
Yes,
had
you
this
don't want to
conversation.
do when your wrist is flaring up. Get late.
Exactly.
Yeah.
I honestly started my testosterone on a regular after last year's ISSWSH when you and I sat there and you're like, why aren't you using testosterone for your hip pain on a more regular? I'm like, well, maybe I need to be better.
Did I say that?
Yes, you did. And then I was using it more regular. And then my
And
friend,
it helped?
it totally helped. And then
God
my friend,
bless.
Dr. O'Sullivan, figured out, and we don't know why, but she's like, Heather, stop rubbing the damn testosterone on your wrists at night. She goes, I have a feeling it's doing something weird. Stopped rubbing it on my wrist. And guess what? My carpal tunnel went away. I started rubbing it every day on my thigh. We don't know why.
Oh, that's very interesting.
We can't figure it out. So when I figure, I've stopped telling my patients to rub it because I'm lazy. I'm like, I'm going to put my dollop of testosterone on my arm, rub it together, because then I can just jump in the bed and I don't have to wash my hands if I've already washed my face and everything. And then I won't transfer it on to anybody. And my wrists were bothering me for months.
Very interesting.
I
worry about, I mean, the inside of your wrist is not very hair bearing, but I'm like, we could get hairy wrists.
But I wondered if it was because, like, Dr. O'Sullivan and I were like, is it because maybe it's less surface space? So she's like, put it on your thigh. I swear to God, dude, like it went away. It's been gone for 4 straight months since I stopped.
I believe you. That's amazing. I think people don't understand the role of testosterone in pain receptors. Like we've got data looking at migraines are less when people have higher testosterone. There was just an abstract. I feel like I shared this with the group. I can't remember. With testosterone correlated with the risk of Parkinson's disease.
We just talked. Yes. We share it with us yesterday. And I'm like, oh
Yeah,
my gosh, I have a friend with Parkinson's and she
that's
is
right.
awful on her cycles. We just talked about
Her
this
Parkinson's gets worse
during her periods.
during her periods when her hormones are low.
Hmm.
Yep.
I think there's a total correlation. She's also had Parkinson's since she was in her late 20s, and they don't know what to do with her because females very rarely get it. So they don't even, she's
Yeah.
young too.
That's Michael J. Fox, I think, was 28 or 29.
Yeah, young.
That's really young.
And of course, he at least was a male. She's a female. No one knows what to do with her.
Right. Well, and he also was like the most famous actor at the time.
Yeah.
So lots of resources.
But
I think
we have our text chain and we talk about this stuff all the time. And even still, we're figuring out like we don't know everything and we're always learning from each other or anecdotally.
Totally.
I mean, what stuff do we bring to our group?
Totally. I mean, that's the other cool thing about Ishwish is nobody goes to Ishwish and is like, I was kind of thinking this might be interesting. I don't know. Like people tend to be, if not, they're all in once they do a course or do the course, you'll be all in. But like they're at least like 80%. Like you got to be ballsy to like show up to a sex conference, I think. I don't know. But when I went to my first one, it was like the 10 a.m. coffee bar. You go out in the lobby and you
That's
get
your alley. That's your jam.
God, yeah. There. Like how close to 10 a.m. are we basically?
You're like,
and
can we start this at like 8? Just wait.
Yeah. Can we start the conference earlier if I get coffee earlier? So I'm at the coffee bar at the 10 a.m. at the fall course. And across from me at the coffee bar is Dr. Ashley Fuller, who's a gynecologist who I went to medical school with, and we did our general surgery residency together. And she had very clean, fancy, new pink Danskos in med school, and I just remember that. And so I'm looking at her across from the coffee bar, and I'm like, what the F are you doing here? Because that was in my beginning of education, thinking that gynecologists knew all of this already. And she's like, and she went to like one of the best gynecology or OB-GYN residencies in the nation in Texas, whichever one delivers like thousands and thousands of babies. So like prestigious place to train. And she's like, Kelly, we didn't learn any of this. And that was like, okay.
And that is
Houston, we have a problem.
Yes. And that is why, let me repeat again, ISSWSH is so collaborative because she and I are on this other text chain with it's 2 NPs and 2 MDs, and we call ourselves what do we call ourselves? Maybe we are Vulva Posse. And we send each other like the craziest vulvar cases, and we snap all these pictures and all the things. And I love her. And like I said, if you're experts that we now feel we're experts have to have a text chain with each other for hard cases, like like we're hitting novel stuff that hasn't been researched and that we haven't been taught.
Yeah. The other cool thing is like if you see somebody who is ISSWSH trained or in the ISSWSH organization, if you go to the Find the Provider. First, the side note, people are going to think that ISSWSH is paying me for this podcast right now. They are not.
I'm not getting paid either.
Heather's also not getting. We're just super fans. Check it out. Explode their membership. But what was I saying? Oh yeah, if you go to the Find a Provider on the ISSWSH thing and you see somebody and they're involved, like they know all the other people. Like they're connected, so like they're better problem solvers than somebody who's like trying to do this alone or stuff.
Well, that's what I tell my difficult sex med patients. I'm like, oh, you have me stumped. But wait a minute, I have an arsenal of this many people I'm going to text, and I'm going to say, do I have permission to send your vulva pictures? And they're like, please. I'm like, it's like this mind blow.
Yeah. No, it's the best. That's what I tell them. Like, if I don't know the answer, I'm friends with everybody. Which is very awesome. I want to talk about the testosterone guidelines. They came out in 2019, if I'm remembering this correctly. Do you think they're due for an update?
I think they actually are in the process of doing it. I remember hearing about this at our annual meeting and our board meeting, I should say. I think that, and maybe it's the HSTD consensus. I think they're both getting updated. I could be totally like making that up in my brain, but I hear so many things in our board meetings, but I believe that is on the docket.
I think they need to open it up to premenopause, perimenopause. I think I think it's very, I don't know, what's your opinion? But I'm like, I think it's very, first of all, having no periods means butt kiss when it comes to if you are a testosterone candidate or not. So the premenopause, postmenopause thing is meaningless, and it's safe. I don't, this, if you get pregnant, stop your testosterone, but it's not contraindicated if you have a chance of pregnancy. We let trans men get pregnant, right? Like, so I
that's
think,
what's going to guide us. I think the trans care, that it's becoming so important, I think that's going to be used more of a guide. When we've talked about all our testosterone stuff, I'm always like, if we can get more guidance on trans, that's what's going to help us as females.
yeah, there was this new paper, I think Jen just shared it with that group, that they looked at trans men on testosterone, and the heart muscle basically got stronger, but no negative parameters of the heart got, it doesn't hurt your heart to take 10 times the dose of testosterone. Like, that's what the paper says. And I was like, well, yeah, we've got 50-year safety data showing that nobody's dying more of cardiovascular disease. Right. And she's like, but we need more papers to show, like, we can give people 10 times the dose of testosterone and it's still safe on their heart. And like, there's no other medication that we're like, hey, anybody want to take 10 times the dose and we'll see how you do? Like, it's an amazing opportunity, and I don't think we emphasize it enough.
Well, you want to know what's interesting is we always talk in our group text how everything is always extrapolated from the male data. Oh, they did research on this as males. Oh, okay, we'll extrapolate it to the females. Well, we have tons of data on birth control pills and females with exponential amounts of this synthetic hormones. Why can't we extrapolate lower dose hormone care that is not synthetic to females if we can extrapolate male data?
Yeah, totally. Well, I think I did a post on this because it's like, we study blood pressure meds in men and then we give them to women. We study sleep meds in men and we give them to women. We study cholesterol drugs in men and we give them to women. But we're like, but let's not take any of the safety data we have on testosterone in men. It's
And give
depression.
it to women.
Yeah, it's depression benefits, it's mood benefits, it's, insulin resistance benefits, it's strength benefit, all the things. We're like, yeah, but we don't have female data. And I'm like, excuse me, we didn't have female data for the sleep pills either. Like,
the word
that didn't stop anybody from FDA approving it for everybody.
It's just crazy. Hormones in females, it goes back to, I hate to say it, I'm going to say it out loud on the podcast, delete it if you want, but we hate women. We've had this, we just don't like women.
That's going to be like, this is Ishwish, is like, every organization needs a tagline. Ishwish should be like, Ishwish, because we don't hate women.
Because we love our women or something. Yes.
I love it. I think the question, for just to go on testosterone for a hot more second, is like, to say that there's a level that we diagnose low desire at, or that we treat testosterone to, it's a gross overconfidence in our laboratory values, in understanding what normal is, in understanding what your testosterone receptors are, to understanding your metabolism of it. Like, it's like, it takes an expert to understand. Like, a lab value is pretty meaningless. There was just a paper that got published in this month's Journal of Sex Med. Davis was the lead author. Basically, the gist of it was that, like, we don't really know that testosterone even correlates with low desire in premenopausal women. And I interpret that as, I always interpret it as, like, desire's complex, right? But like, we didn't know what these women's testosterone was when they were 22 and had desire.
Right. We weren't
like, there's so much we don't know. And I just worry that papers like that, they're going to be like, see, testosterone doesn't work. That's not what it says. It just means it's more complicated than we understand.
Well, what if we got away from the labs? Like, what if we take the Menopause Society's adage, just give them their hormones. We don't need to test for it. We don't have to take estrogen and progesterone, which is not always what I do. A lot of times I do get labs, for better, for worse. People can hate me for it, but I do. But what if we just give the testosterone and we don't go by a parameter and say, hey, are you feeling the effects of it? Are you feeling too much of the effects? Like, what if we treated it the same way and don't have a lab parameter?
I think the lab parameters, first of all, like Quest, I'll pick on Quest for a hot second. Like normal goes down to like 5 and high is above like 34 or something. I'm making those up, but that's the range. And people use that as gospel
for females.
for females. People use that as gospel of like, it's too high if it's above or it's not low enough. And it's like, no, we got to like even get rid of what we think the normals are because we have more papers showing normal than the lab value is using.
Oh, 100%. Because it's based on, like, we don't talk about optimal. Everything has to be on these ranges, which for the most part are off males. So they're not off females. And it also depends on when you did the labs. Like, LabCorp is going to tell you one number, which Quest is going to tell you which another. And then don't get me started on these woo woo like Dutch and all the other things people are using. I mean, like, at least give us the tried and true blood, the gold standard, you know? But then there's variation. Like, what if they drank the night before? What if they were dehydrated? What if they were sick? What if they're on biotin? Like, there's just so many parameters.
What if they didn't get sleep?
Exactly.
Totally.
I was talking to a colleague about men's health actually today, and she's like, you know, we have a lot of people that'll say, oh my God, your H&H is so elevated, go give blood. I can't give you any more testosterone. And I don't do a lot of male health. So she was just kind of saying, she goes, but the problem is, she goes, no one asks the questions pre-testosterone, like, how much do you drink? Were you dehydrated? If you're one step dehydrated going to get your blood work done, you're probably going to have a high H&H.
Yeah, totally. By definition. And so many people do get labs fasting because they're kind of trained to think you need to get fasting labs. It's just, so many people are like, I have an elevated creatinine. I'm like, were you hydrated? They're like, no, I was fasting. I'm like, okay, well, maybe we should check a hydrated creatinine before we go down that pathway. Well, this has been an absolute pleasure. We didn't even scratch the surface of what happened at ISSWSH 2025. So
we talked about all our other tangents, which is amazing. The research also, we'll have to do another one. The research that comes out every year is amazing. Tons of posters. We're free. So if you listen to this and you want to submit an abstract, we're free. Please do. We had 220 abstracts submitted this year. I think we took over 200 or maybe we had 240 and we took 220, biggest amount we ever had.
That's amazing. ISSWSH Conference 2026, Long Beach again. We have the dates. I believe they're in February.
They actually fall around Valentine's. I think it actually is on the President's Day weekend. I'll tell you. Hold on. It's February. I think it's 12th through the 16th, I think.
Cool.
Right around there.
But if you're a newbie or a beginner, you want to dip your foot in, I can't recommend the fall course more strongly.
Yeah, it'll be in November.
Thanks for coming on and chatting all things women's health with me today. It was great.
Thanks, my friend.
Talk soon.